Psychiatry, behavioral science, and substance use disorders. We are still looking at the first block. So, yesterday we solved 5 questions. Today we're going to solve 5 more. And hopefully, you can get something out of this and understand how to approach the questions. So, what is my idea with this way of teaching, and what do I hope to achieve? I've already explained in the previous lesson, but today we're just going to continue looking at some more questions. So, which of the following is the most likely diagnosis, right? The most easy type of a question that you can get. 19-year-old man, he has some behavioral changes over the past year following an unexpected death of the father. He has become increasingly socially withdrawn, stopped responding to friends' messages, lost interest in schoolwork, and failed to graduate from high school. For the past several months, he has spent most of his time alone in the room listening to music and drawing. Mother reports that his drawings of a number consist of numbers in various colors and sizes, become preoccupied with the exact date and time of his father's death, believing these numbers have special meanings. During conversation, the patient frequently changes topics and makes random remarks, making him difficult to follow. On mental status examination, he pauses before answering questions, gives brief and unrelated responses, avoids eye contact, and displays a blunted affect. So all of this is important. He denies suicidal ideation and does not report hallucinations. So you can pause the question and think about the answer for yourself. Okay, so the boy definitely has a psychiatric disorder because of this part. That these numbers have a special meaning, right? So this part, because of this, he definitely has a psychiatric disorder, and he has had the psychiatric disorder for the past year, right? So he could go towards depression as his father died, but there are no simple, there are no symptoms of depression also, and also depression is not present in the options. So they've made it quite easier for you. Normal bereavement, which means normal grief response, is not in this question. It's not the answer to this question because it has been an year. So after a year, if there is normal grief in a patient, after a year, the patient starts to get better, right? And the year is a maximum time. By the passage of 1 year, the patient becomes better. The patient starts to adapt to the absence of anyone, to the absence of the death of any of your loved one. He becomes to adapt. So since he's still affected after a year is passed, this cannot be normal bereavement, right? Can be delusional disorder, cannot be obsessive compulsive disorder, cannot be post-traumatic stress disorder, can be schizophrenia. Now, the first thing that I want you to understand is what really schizophrenia is. Schizophrenia basically is the disorder of thought, the disorientation of thought, the disorder of thought, the breaking of thought, the breaking of thought, right? I want you to remember schizophrenia by the fact that your thoughts are broken. You do not answer questions in the way they are asked. You do not think in the right way. You do not think linearly. You think of 10 different things at the same time, unrelated to each other. You don't give any responses. You are socially withdrawn. So delusion disorder doesn't really have all of that. Delusion disorder will only have a delusion and nothing else. But this patient has a lot of things except for delusion. So I hope you've chosen your answer. Let's move on. So the answer is schizophrenia. Okay, it is schizophrenia. You can read the explanation over here if you want to. You can read it. But we're not going to read this one. We're going to go directly to educational objectives. So schizophrenia presents in the late adolescence or early adulthood with progressive social withdrawal and functional decline, disorganized thinking, and negative symptoms such as blunted affect and reduced speech. Although hallucinations are common, the diagnosis can be made on basis of persistent psychosis. or disorganized symptoms with functional impairment lasting greater than 6 months. So we've learned a few facts in this question that they're trying to teach us basically on how to identify schizophrenia. That's the point that they're making. First of all, you need to remember the first fact is that you need to remember this timeline. And it should be greater than 6 months. Schizophrenia is always greater than 6 months. You need to remember this timeline. Okay. And the second fact you have to remember is that negative symptoms are present in schizophrenia. They might not be present, but most of the times they are present. So the content effect and reduced speech and social withdrawal also is present. So this is the second fact that they want you to know. Okay. And the third fact is that the patient has functional decline and disorganized thinking. These are the positive symptoms, which means the psychotic symptoms. Right? These are the negative symptoms. These are the positive symptoms, and this is the timeline. So this is the first fact. This is the third fact, I should say. So there are three facts that they want you to know. The first is the time. So the first is the time. The second is the negative symptoms. And the third is the positive symptoms or the psychotic symptoms, whatever you want to call them. So this is how you're going to diagnose schizophrenia. You must know these three facts that I'm trying to tell you. Okay. Now we touched upon the fact that this could be the right answer, but it does not really cause persistent disorganized thinking, severe function decline, or any negative symptoms for that lasting over a year. This is the important part. It does not last over a year. It only lasts mainly for a year, right? So you can read the explanation if you want to on this page as well. And you can read it over here as well. But that is it for this question. Right. Which of the following clinical pharmacologic effects of buprenorphine is most likely? 34-year-old man. He's being evaluated, treated for opioid use disorder. He was prescribed oxycodone for a sports-related injury, but subsequently developed and transitioned to intravenous heroin use. For the past several years, he has been experiencing overdoses, requiring naloxone treatment. He attempted to stop using heroin on his own, but relapsed several times. Now been abstinent for 2 days, but reports strong cravings. After discussing treatment options, he started on buprenorphine. The dose and the response curve for this medication demonstrates a ceiling effect on opioid activity. So the following clinical pharmacologic effects of buprenorphine is most likely. This is a bit difficult question. Difficult because this is a basic sciences question of pharmacologic function, basic pharmacologic function. So first of all, you need to have a basic history of what buprenorphine is. So buprenorphine is a partial agonist, right? Naloxone is an antagonist, right? Buprenorphine is a partial agonist. So what a partial agonist basically does is, if I could explain to you what a partial agonist basically does, I don't know for what reason my pointer is acting up. So if I could tell you what a partial agonist usually does, right? Basically, what a partial agonist is that you know what an antagonist does? It replaces the agonist. So naloxone will come, it would replace the opioid, and the patient would have sudden withdrawal. So the patient would be basically saved from the overdose. That is what naloxone does. Buprenorphine is a partial agonist, which means that it can also react with the receptor of opioid, or it can also displace opioid. It can work like an antagonist and also an agonist. It can work like both of them. But the problem is that in which way buprenorphine acts depends on when you are giving buprenorphine. which way, right? So if you are giving buprenorphine before withdrawal effects or cravings are started, what buprenorphine is going to do is going to displace whatever opioid is left on the receptor. It's going to displace it, and it will precipitate withdrawal symptoms in the patient. If the patient is not feeling any withdrawal symptoms, when you give buprenorphine, the patient will feel worse. He will feel bad. He would feel the withdrawal symptoms suddenly. But if the patient is already feeling withdrawal symptoms, just like in this case, if the patient is already feeling strong cravings, then if you give the patient buprenorphine, the patient is going to feel better because now you're giving him something like opioid. And buprenorphine, because of its partial agonist quality, is going to react with the receptor. So, body is going to think that the patient is receiving opioid, so the cravings will decrease. Right? But in reality, he is not receiving opioid. He's just receiving a compound that is less potent than an opioid. So it's going to do less damage than an opioid. So that's how we use buprenorphine. It's basically, if we give it before withdrawal symptoms, it can precipitate withdrawal symptoms. And if we give them after withdrawal symptoms, it can basically cure the withdrawal symptoms. So mostly it is used to treat patients with opioid use disorder. And what it does is basically we give them to patients that are feeling a lot of withdrawal symptoms. So we give them to pacify their symptoms a bit, to give them a bit of a peace, so that they could maintain that they could maintain the uh, their sobriety. They could maintain the sobriety and their abstinence for a longer period of time. They could maintain that. So if the patient is going to feel withdrawal symptoms constantly, he's not going to be able to maintain that for a long period of time, right? So this is what basically buprenorphine is. It's used to decrease the cravings of the patient. And how it decreases the craving of the patient, because it can react both like an opioid and also against the opioid. Depends on whenever you give it. Now, there's something that you should know is that the dose response curve for this medication demonstrates a ceiling effect. Ceiling effect, what it basically does is, if I could show you, this is the graph, right? This was actually given in the original question. This is a ceiling curve. So this is the curve of an opioid. This is an opioid curve, heroin curve, right? You can see that if the dose increases, the binding is going to increase. So more heroin is going to bind to more receptors, and of course going to do more damage to the body of the person. But this is the curve of buprenorphine. You can see that the more dose you give, it doesn't do any you can say any increased binding. So this, in fact, uh, buprenorphine is basically beneficial for the patient more than heroin, right? So there's going to be no overdose. There's going to be no ill effect, and some effect of opioid the patient is going to get, which means some of his cravings are going to be soothed, and he's not even going to have any bad effect, any negative effect of an opioid. So he's getting the good effects of opioid, and he's not getting any negative effects of opioid. So that's why buprenorphine is a very good option for us to use in patients with opioid use disorders. Uh, So I hope you've chosen your answer, right? So based on this knowledge, you can simply, it's a very easy question now. Okay. Uh, it's a very easy question now. So buprenorphine overdose is more easily reversed with naloxone compared to heroin. So buprenorphine overdose does not really happen, because you can see that I've already shown you the graph that it demonstrates a ceiling effect, right? So it cannot be taken in an overdose. The more you take it, it's going to, after a certain point of binding, it's going to stop binding. So it's not going to do much harm. Buprenorphine carries a higher risk of hypoventilation. So we've seen that if buprenorphine does not even go to the level of heroin binding in the body, then how can it affect more than heroin? That's not even possible, right? Buprenorphine can precipitate or treat opioid withdrawal from heroin. This is the right answer. And buprenorphine can fully reverse the effect of heroin overdose. So that is what naloxone can do. Because to reverse an effect of an overdose, you need a strong antagonist. You don't need an agonist. So this is the answer, and you can read it. This is a very good explanation. This is an important explanation. So I would suggest that you read the explanation. Okay. And these are all the options that I explained to you. An education objective is important. So whatever I said, it's a partial agonist with high receptor affinity used in medication-assisted treatment for opioid use disorder. Its partial agonist activity produces a ceiling effect for euphoria and respiratory depression, which means it does not cause euphoria or respiratory depression. It produces a ceiling effect. So it introduces a wall before reaching these symptoms, reducing the overdose risk. Due to its high receptor affinity, buprenorphine can displace full opioid agonist and precipitate withdrawal if administered before withdrawal symptoms begin. So if administered before withdrawal symptoms begin, but it can also relieve withdrawal and cravings when given appropriately. So I hope this was clear because this was a bit of a technical term to explain. Moving on, you can see the graph. Okay, so which of the following symptoms is most indicative of major depressive disorder in this patient? 63-year-old woman with metastatic breast cancer presents with depressed mood for the past month. She reports increasing sadness and frequently cries when thinking about her poor prognosis and death. She has metastatic breast cancer. Over time, she has lost 4.5 kg, has low energy, difficulty falling asleep, frequent nighttime awakenings. She has become socially withdrawn, does not answer phone calls, no longer looks forward to visits from the family members. She also feels guilty about not wanting to spend time with her grandchildren. On mental status, she is alert, oriented, depressed mood, and affect and denies suicidal ideation, which the following symptoms is most indicative of major depressive disorder in this patient. So all of these are indicative of major depressive disorder, but which is the most indicative? Now, whenever they are asking about something that is most indicative, they are basically asking you that which symptom most likely points towards depression. All right, most likely. So if there was depressed mood in the options, that would have been the correct answer, but it's not. So there is always a hierarchy of symptoms that you must be familiar with. There is a most likely symptom, then there is the most important symptom, there is the most dangerous symptom. So low energy, sleep disturbance, and thoughts of dying. Thoughts of dying is also very important. So the most important is the depressed mood, then thoughts of dying, or I guess thoughts of dying is more. Yes, so thoughts of dying is the most important. Then it's depressed mood, and then there's another symptom which is the answer of this question. Now, thoughts of dying is the wrong answer because she denies any suicidal ideations. That's clearly wrong. So I hope you've chosen an answer now. And the answer is loss of interest in family. So anhedonia, they call it, and it's loss of interest or pleasure in previously enjoyable activities or relationships. So look at the explanation now. Then we're going to go to the educational objective. So the patients with severe medical illness, many somatic symptoms of depression, weight loss, and sleep disturbance overlap with the effects of the underlying disease. The most specific features in in major depressive disorder is anhedonia, persistent guilt, hopelessness, and loss of interest in relationships or activities. So this is what the question is trying to teach you. This is what the question is trying to teach you, that you must know these things, which are most specific. The most specific is anhedonia, persistent guilt, hopelessness, loss of interest in relationships or activities. These are the most specific symptoms. So from this question, I want you to memorize these symptoms. This is what you should be taking away. All the other symptoms can be found in an organic disorder, in a somatic disease, in an underlying chronic disease. You can find everything else in those conditions as well. But something that you're only going to find in depression are these things: anhedonia, persistent guilt, hopelessness, loss of interest in relationships or activities. You are free to read the other explanation as well and pause the video and read it. But other than that, I think we should just move on. So, that okay. So, the medication used to treat this patient's depression most likely affects which are the following steps of monoamine neurotransmission. So, the patient has depression, he's been taking a medication. 34-year-old man, due to sudden onset severe headache and blurry vision that begins shortly after eating lunch at a new Italian deli where he consumed a sandwich with several aged meats. Okay, that's a very big clue. Cheeses and drank iced tea. All right. His medical history is noted for treatment resistant major depressive disorder. He has no known medication or food allergies. Blood pressure is increased, pulse is increased, appears tremulous, and diaphragmatic examination. Very high yield question. Very high yield question. You must understand first know what the drug for treatment resistant major depressive disorder is, and then understand what is happening to this patient because of these clues, the meat and the cheese clue, and then go towards the mechanism of action of that problem. So choose the answer first. All right. So let's view the explanation together. First of all, I would just like you to I would like to tell you that for treatment resistance major depressive disorder, so for treatment resistant major depressive disorder, we usually give MAO inhibitors, monoamine oxidase inhibitors, right? And when they are combined with another compound, which is found in these food in these foods, right, in these recipes, then the patient goes into a hypertensive, just ignore the line, hypertensive, tachycardic, and tremulous kind of behavior. So let's look at the answer. That's his monoamine breakdown is affected. Okay. The reason is that let's look at the educational vector. So the reason is that monoamine oxidase inhibitors are used for the treatment of treatment resistant disorder. This is the first. This is the first fact that you must know. They work by inhibiting enzymatic breakdown of monoamine. And patients taking monoamine inhibitors must avoid tyramine-rich foods. So tyramine is a compound which is in these foods, which is aged cheese, cured meats, fermented products, red wine. Red wine is also a part of this. So I'm writing red wine by RW. So red wine is also a part of this. And if tyramine is taken, it can trigger excess norepinephrine release, leading to non-life-threatening hypertensive crisis. So these are the three facts that you must know. First of all, what drug is used in treatment-resistant disorder? All right. Second of all, which food should you avoid? Tyramine-rich food, which food? You need to know the examples: aged cheese, cured meats, fermented products. And then you should understand that which part is broken. So what happens is that if monoamine is not inhibited, it can easily break down any norepinephrine or epinephrine in the body. But since you're already inhibiting it, inhibiting it by taking a monoamine oxidase inhibitor, then you should avoid things that increase it. Because once it is increased and monoamine oxidase is not there to destroy the excess norepinephrine or epinephrine, it will obviously lead to life-threatening hypertensive crisis. So these are the three facts that you need to keep in mind from this question. Three facts explained in the educational objective. See how easy it is to solve questions and understand them. You can skip the explanation if you want, but if you want to read it, then you can go ahead and read it. And you can also read this one. I hope you understand. And if you don't, then you can ask me it. So last question for today. Which of the following is the most appropriate pharmacotherapy for this patient? 44-year-old man hospitalized for acute cholecystitis undergoes an open cholecystectomy. 2 days after admission, he develops anxiety, tremulousness, irritability, severe agitation, becomes verbally abusive. He reports drinking 6 to 8 beers daily for several years but denies tobacco. And everything else is normal. Blood pressure is 160/90, pulse is 110. Physical examination reveals bilateral hand tremors. Classic example, very high yield alcohol withdrawal, 6 to 8 beers per day. So for men, there you should know that two drinks per day, 2 drinks per day is good, which means 14 drinks per week. And for women, it's half than that, so it's 17 drinks per week. Okay, so obviously he's drinking a lot more, and he has been in the hospital, so he's not getting anything to drink. So that is why he is he has developed these symptoms. So you must remember these symptoms. You must remember these symptoms. This is a very high yield topic. First fact, you must know the limit of drinking so that you can identify that he is alcohol dependent. Second, you must know these symptoms that develop on alcohol withdrawal. And third is you must know the treatment that they are asking you. So let's move forward. The answer is chlordiazepoxide, which is a benzodiazepine. Chlordiazepoxide is a benzodiazepine. So read this whole explanation. But the most important part is over here. So alcohol withdrawal is there from CNS hyperexcitability, of course, because alcohol dulls the CNS. So once you stop giving it alcohol, it will do excited. And these are the symptoms you must remember: tremor, agitation, anxiety, hypertension, tachycardia. They typically begin with 6 to 24 hours. And benzodiazepine is the first line treatment for withdrawal, seizures, and delirium tremens. This is also known as delirium tremens. It actually occurs after 2 to 3 days. 2 to 3 days, you can see. Seizures can occur after 1 day or 2 days. So benzodiazepine is the treatment option. So you remember three facts. First of all, the limit of drinking, and then the symptoms of alcohol withdrawal, and then the treatment of alcohol withdrawal. So three facts you must remember from this question as well. That's how you will be able to solve it. Other facts you will get to know. You can read the explanation if you want. I'm holding the screen over here. Other things you will get to know as you solve more questions. But from this question specifically, I want you to take three facts that are most important. For every question, I want you to take three facts that you're going to remember. And if you read this as well, if you want to. And then we're done.